Good evening. It's 1st March, Mahashivratri, and we are back. Welcome all the dignitaries and delegates for our journey towards knowledge. From its inception, from beginning, there is an emphasis on clinical pediatrics and to choose the published articles which are useful for our day-to-day practice. This episode also, I believe, will be a great learning experience. Thank you all. Over to Dr. Manju.
Thank you, ma'am. I, Dr. Manju Saibhai, welcome you all to the 3rd edition of Journal Journey of year 2022. This interesting activity is conducted by Maharashtra IAP in collaboration with Raigad IAP. Like every time, this time also we have very interesting topics. But before introducing topic, I would like to request Dr. Hemant Gangolia, sir, President Maharashtra IAP, to say a few words. Welcome, sir, and over to you.
Thank you, Dr. Manju. Good evening, respected dignitaries, experts, speakers, office bearers of MahaIAP and IAP Raigad, and all attendees on this Zoom dais as well as YouTube channel. Once again, day 1 of new month. We are back with journal episode, the aim of which is how to read journal articles and present them, which will be helpful in and useful in day-to-day practice. I am very happy to have the speakers from the small but very enthusiastic branches from Maharashtra State, Hingoli and IAP Bid. And as an organizer, would like to have more involvement of more branches across the state. We are very fortunate to have eminent experts, Dr. Mamta Manglani Madam and Dr. Nimen Mohanty Sir, who is the backbone of this journal journey. All the best wishes and wish each one happy learning. Thank you very much.
Thank you so much, sir. Now I welcome and request Dr. Mankhede, sir, President Raigad IAP, to say his thoughts.
Thank you, ma'am. Thank you very much. It's really a great journey of journal journey. Actually, it began from Raigad IAP. एक छोटासा वृक्ष आम्ही लावला होता, त्याचा एवढा मोठा वटवृक्ष होईल असं वाटलं नव्हतं. त्याची व्याप्ती पण वाढत आहे. So, and more eminent personalities are joining. They are getting involved in this program. We are happy to know and happy we get opportunity to learn about different topics, and we get opportunity to listen our experts. I extend my best wishes and I congratulate this program. Thank you very much.
Manju, unmute. Manju, you have to unmute.
Few requests to all. Please type your queries in chat box. All your queries will be answered during question and answer session. And I request all the experts and dignitaries to stick to time as we have a limited time duration. So now we will move on to our first topic for today's journal journey. The name of topic, as you all know, is iron deficiency anemia in suspected celiac disease. As we all know, celiac disease is an autoimmune disease affecting villi, microvilli of intestine, and therefore causing malabsorption of various nutrients and causing various deficiencies. Iron deficiency is one of the prominent thing, and sometimes it can be the presenting sign of celiac disease also. So let us invite Dr. Snehal Nagre sir and for today's first article. And we are also very fortunate to have Dr. Mamta Manglani madam as an expert. I request Dr. Jay Bhandarkar sir to introduce our speaker and our expert for first topic of the day. Over to you, Jay sir.
Thank you, Manju, and thank you, Chitara madam. At the outset, good evening to all of you present here, and see to all the names taken by Dr. Hemant here. As a houseman of the pediatric, I just continue what you said or the prior all the speakers. जो जूनियर था तो अभी मैं उतना ही जूनियर और ज्यादा जूनियर हो गया. जितना इतना सुन रहा हूँ कि नया आइडियाज मैं निकालता हूँ, उसमें लगता है कि मुझे काफी कम ही मालूम है. I hear sincerely thanks from my bottom of heart to Dr. Mamta Manglani. She accepted Jay, ये नाइट में है कैसे होगा? तो मैडम मैंने बोला आपको ही आना है, there is no choice. नहीं और किसी को भेजूंगी, मैडम चलेगा नहीं, आपको ही आना है. तो I hear I love to introduce Mamta Manglani madam. So I have worked with her in a 2 pedicon and even MBCon, even at DAFL CME. So nice lady, I can say. Always जब मिलते हैं ऐसे लगता है कि सालों से जानते हैं from first day. So she's a director from this MCGM Comprehensive Thalassemia Care Pediatric Hematology and Oncology BMT Center, Borivali East, a satellite center for LTMG College and General Hospital Science, Mumbai. She's the former professor and head of Department of Hematology and Oncology, Program Director, Pediatric Center of Excellence for HIV Care, Department of Pediatrics, LTM College and General Hospital Science, Mumbai. She started first public sector and bone marrow transplant in country at LTM College, and it was an 8-bedded unit at Borivali Center also. She received 7 Oration Awards and 19 awards for a research paper. Training in the pediatric hematology, oncology, Robert Johnson, University of Medicine and Dentistry, New Jersey, USA, 1997. And she had a fellowship in pediatric HIV at this Somerset, New York, USA in 2004. And she's written in chapters in pediatric hematology oncology, chapter IIP 2018 and 20. And presented very local, regional, national, international conference, almost 542 presentation and publication in various journal in one day. I can say she's like a Sachin Tendulkar of hematology of IIP India. So I again sincerely thank Madam for this, her presence in this journey journal hour. We started last year on the first Doctor's Day, and I was the first presenter because no one was ready to present immediately some topic. सो मैडम मैं आपसे फिर से तहे दिल से शुक्रिया अदा करता हूँ कि आपका प्रेजेंस यहाँ पे बहुत इंपॉर्टेंट है हमारे लिए महाएपी के लिए, सो दैट दिस जर्नल कंटिन्यू लाइफ लॉन्ग ऑन दिस डायस, सो दैट वी विल work towards different articles and engage in various academic activities. And I also sincerely thank Dr. Sehal Nagre. No one is small when you come to the pediatric, when you stand between life or death of the pediatric patient and the disease. And I this introduced Dr. Snehal. He's almost practicing 23 years at Hingoli, and was the IIP president of Hingoli as well as IMA Hingoli. Very active person. Plays like मैं रोज बैडमिंटन खेलता हूँ, डॉक्टर स्नेहल रोज लॉन टेनिस खेलते हैं. And was the first person to call organizer of Mahapedicon. Sir, best of luck for the Mahapedicon 2021. So ये मेरे दिल में बात रहेगी लॉन्ग टर्म में. डॉक्टर स्नेहल को कभी भूल नहीं सकता. When I heard Snehal, I was very humble to say कि I was expecting some very क्या बोलते हैं beautiful lady, but he turned out to be beautiful Mr. Snehal for us me on that day. So I open the topic here, and I again go to the MOC to start this presentation. And but I will want to say Dr. Mamta also Manglani madam to say few things. Yes, थोड़ा format है लेकिन मैडम कुछ बात करने को ज्यादा अच्छा लगेगा. Thank you.
Thank you, Dr. Bhandarkar. It was wonderful listening from you, the introduction, because you glorified so much. I'm not sure whether that's how I deserve it. Anyway, thank you very much. I think this is a wonderful, program that you all have started as Maha-IIP and IIP Raigad. And I congratulate Dr. Gangolia and all the IIP Raigad OB and EB members for doing this wonderful thing. Because I think when we are out of our academic institutions, by and large, what happens is journals are considered only as a reading material whenever there is a case in which we have a difficulty. And we really do not do it as a routine reading to understand how to evaluate a journal article and whether to take every article seriously or not. Because there may be so many articles which are written with very little background scientific work and published without much statistical evaluation, which is properly done. Those type of articles can mislead us in our practice. In fact, therefore, when following any article's recommendation, we have to evaluate the article correctly, whether this article is worth considering in my practice, because it is not done properly, the numbers are less, the randomization is absent. So evaluating and grading an article for its science is also an equally important part of the journal journey. However, I'm not sure what is the aim and objective of today's discussion, but however you will lead me, I will be ready to contribute in that manner. Congratulations once again, and thank you for inviting me.
Thank you so much, ma'am, for your encouraging word. Now I will request Dr. Snehal sir to start with his presentation.
Hello.
Yes, sir. We can hear you.
Screen sharing. Can I?
Please do. नाही झाले अजून.
Yes.
Yes, I am sharing my screen.
Yes.
It's okay now?
Full screen.
Yes, sir. Yes. Full screen.
Yes, yes.
Yes.
Welcome to the third episode of Journal Journey. Journal Journey is a research product of IIP Raigad. Today's journey is from IIP Raigad to IIP Hingoli via Neral and Satana. This means Maha-IIP have traveled from Raigad via Neral, Satana to Hingoli and Bid. This means Maha-IIP reach every corner of Maharashtra. This is the vision 2022 of Maha-IIP's president, secretary, and whole team of Maha-IIP 2022. I am very delighted as I am presenting an article from a journal after 24 years, that is after completion of my post-graduation. Today I am presenting an article from Journal of Gastroenterology and Nutrition, volume 64, number 1, from January 2017. The title of the article which I am presenting today is Anemia and Iron Deficiency in Children with Potential Celiac Disease. The authors of this article are Marlena Repo, Katri Mackie, Kaija Luike, and Kelly Koppa. Introduction. Celiac disease is a lifelong disorder characterized by a heterogeneous clinical picture. Recent screening studies have revealed the prevalence to be 1 to 2%. The only treatment for this condition is permanent gluten-free diet. The diagnosis and classification is based on morphological damage of small bowel mucosa. Also, serological tests measuring antibodies against trans-glutaminase 2, that is TG2 antibodies, and endomysial antibodies are now available. Interestingly, clinical experience suggests that children with potential celiac disease show signs of anemia and subclinical iron deficiency. Now, what are the objectives of this article? Active screening of celiac disease frequently detects seropositive children with normal villus morphology, that is potential celiac disease. It remains unclear whether this subject should be treated or not. We have investigated the prevalence of anemia and iron deficiency in children with potential and mucosal atrophy celiac disease. Population. This prospective study involves 19 children with potential disease, 67 with partial or subtotal villus atrophy, and 16 with total villus atrophy. 23 healthy children included as control group. Intervention. All participants underwent a thorough clinical examination and blood sampling for serology and laboratory parameters. The groups were compared for various clinical, histological, and laboratory parameters and hepcidin. Outcome. The development of anemia and iron deficiency in a celiac disease is a continuum, that is in a sequence, and may already be present in children with normal villus morphology, advocating an early diagnosis and possible dietary treatment of these patients. Time duration. The children with potential celiac disease were monitored every 3 to 6 months during the study period of 2.5 years. Now, what is the study design? This study was conducted at Tampere University Hospital. This is a tertiary care hospital in Finland. It involves consecutive children below 16 years referred to this tertiary care hospital due to celiac disease suspicion and serology positive for celiac disease. Exclusion criteria were study refusal and negative serology. Blood test for serology and laboratory parameters done in all participants. Gastrointestinal endoscopy with duodenal biopsies was performed under general anesthesia. Children with established villus atrophy with crypt hyperplasia labeled as celiac disease, and they straightly kept on gluten-free diet. Those children with positive autoantibodies but morphologically normal villi, that is potential celiac disease, continued on normal diet. These children monitored every 6 to 3 months, and a new endoscopy performed in mark if there is marked increase in antibody titers or worsening the children. Now, what are the results? The median values for hemoglobin, total iron, ferritin, transferritin, iron saturation were significantly lower in total villus atrophy group compared with other groups. Anemia, low iron, low ferritin, and decreased transferrin saturation were more common in children with advanced histological damage. See, these are the results. The prevalence of abnormal parameters was as follows. The parameters were was anemia, low iron, increased transferrin receptor, low ferritin, low transferrin saturation, and these all figures are in percentage. So anemia and low ferritin in control groups it was 0%, while it was 63 and 87% in total villus atrophy group. After a median of 7 months on a gluten-free diet, hemoglobin, total iron, ferritin, and albumin in children with in partial or subtotal villus atrophy exceed the baseline values in potential celiac disease group. Both endomycin antibodies and TG2 antibodies, that is transglutaminase 2 antibodies, differed significantly between the study groups as their concentration increased parallel with the severity of mucosal disease. There was no difference in hepcidin concentration between subgroups with or without anemia and low ferritin 2. Now, lastly, what is the strength of the study? This is a prospective study, and variety of clinical, histological, and serological parameters were measured. Also, particular attention was paid to the precise histomorphological analysis of the biopsies and thus correct histological grouping of the participants. Now, what are the limitations of the study? Relatively small number of children with potential celiac disease disease group was there. So this hampers the statistical evaluation. Also, in potential celiac disease group, normal diet was given. Hence, it was not possible to evaluate the effect of gluten-free diet on their hemoglobin and iron parameters. Now, what is known to us, an increasing number of children with positive celiac autoantibodies but morphologically normal small bowel mucosa are detected by active finding and screening, that is potential celiac disease. It remains unclear whether these subjects with potential celiac disease should be treated with a gluten-free diet or not. And what is new? Celiac disease associated anemia and iron deficiency are a continuum and may appear in a seropositive children even before morphological villus damage. These children may benefit from early diagnosis and dietary treatment. Thank you.
Thank you, sir, for this wonderful presentation. Now I request our expert and other present dignitaries to discuss on this topic further.
Thank you. Yeah, thank you, Dr. Snehal, for a wonderful, overview of the article, because it's sometimes very difficult which points to include and which points to keep away. So you very nicely capsuled it and given it to us. A couple of comments. One is this study has a good strength because it has included almost 100 children with potential celiac disease. with various levels of atrophy. So the strength is not bad because you can't get more than this number in celiac disease. The other aspect where they have said limitation is that there were lesser number because this disease is not as common. That can be overcome sometimes by doing multi-centric studies, so that you pool patients from various centers to get a good number, so that you make meaningful conclusions out of the study. Of course, coming to the crux of the study, which has talked of whether a potential celiac disease has a concomitant iron deficiency and how should we go about in clinical practice. So my take would be that iron deficiency anemia, which does not respond to oral iron therapy. And what do we mean by not responding to oral iron therapy? Is that after giving appropriate doses of a right compound in right doses, in the right way, sort of on empty stomach or before reclining to bed in the night, so that you're not going to eat anything after that and you've had your dinner about an hour before. So that type of, and not giving too much iron too regularly, rather too frequently, that is giving intermittently if possible, because today there are theories which have shown very clearly, because of the hepcidin related regulation of iron absorption, that it blocks the absorption once it takes some amount of iron into the gut. So you have to give iron maybe alternate days, may not be, or maybe once daily. We used to give 2 to 3 times in the past, if you all recollect. So that again practice should be taken into account. So if you're giving like this at night once, after dinner, after 1.5 hours, preferably in the night, because the motility of the GI tract is low and therefore absorption is better and side effects become little lesser. So this is the reason, because of the motility being low. Now, having given iron in this manner for at least 4 to 6 weeks, if we do not see an increase of more than or equal to 1g% in hemoglobin, ideally this increase should happen within 2 weeks. But we do not judge response, or rather failure. Response you can judge if there is an increase by 14th day, but do not judge failure of oral iron therapy based on this. Before even concluding that this is failure, you have to check on compliance or adherence to the therapy. Now, once having checked adherence, if we know for sure that the stool color is altered, there is a discoloration of the tongue and mouth with syrups being given to a younger child, and there is some kind of little GI symptoms happening to the child, then you know that the patient is taking your iron syrup that you have prescribed. Best salts to be given are ferrous sulfate, ferrous fumarate. I prefer ferrous fumarate, but it's a personal choice, nothing specific. Side effects are probably slightly lesser with ferrous fumarate compared to ferrous sulfate, but both are equally effective salts. Ferrous gluconate is also good. Ferrous salts are preferred compared to ferric compounds, because only ferrous gets across the brush border of the intestine, and it has to be converted to ferric once it is across the intestinal mucosa. Now, having said this, if you have failure to oral iron, then and then only there is an indication to rule out celiac disease or potential celiac disease in children. Of course, our part of the country, Western zone or Maharashtra, does not have that high incidence of celiac disease. Correct me, Dr. Monty is an expert. I may be wrong, but I feel I have not seen that many cases as my North Indian counterparts have seen or colleagues have seen. They have seen quite a bit. In fact, PGI, Chandigarh, AIMS, these people always keep reporting celiac disease with iron deficiency in ANIMAT conferences, whereas we do not see that much. We have seen a couple of cases in a year, or even sometimes lesser than that, proven celiac disease. The beauty of this article, what I found, Dr. Snail, was that they're talking of potential celiac disease, where there is no great proof on intestinal biopsies, except for sometime a villus atrophy, which may be partial, total, or subtotal. Having given that why it should happen at all in a patient who's not even got villus atrophy, the explanation in literature is that there are ultrastructural and molecular changes which do not get corrected even after gluten-free diet has been given for between 2 to 5 years to these children. And therefore, these continue to cause the iron malabsorption. Additionally, the disease is not limited to the gut. There can be extraintestinal inflammatory manifestations like arthritis and other problems. There can be coexistence of inflammatory bowel disease of other kinds. There can be blood losses happening along with because of extensive ulcerations which happen in severe celiac disease. So just gluten-free diet is not going to solve all the problems of iron deficiency, and not have iron deficiency, especially in a potential celiac disease, because inflammation can lead to anemia of chronic disease, which reduces the iron utilization at the microscopic level, and iron reallocation to the serum does not happen, and there is a increase in hepcidin molecule due to inflammation as an acute phase reactant. Whenever hepcidin is upregulated, there is a reduced absorption of iron and reduced remobilization of iron from the macrophages and RES system. That leads to, again, a non-availability of iron at the bone marrow level for producing the red cells. This causes, again, a microcytic hypochromic anemia at the periphery. So these are the few aspects which we must remember, that celiac disease is not just a disease of the gut. It is a systemic disease. It can have inflammation, inflammatory markers, cytokines like TNF-alpha, interferon gamma, IL-6. These are increased in these patients, even when they do not have prominent villus atrophy. And this itself can lead to a problem with iron utilization as well as absorption because of hepcidin regulation. So I think these are few factors which we must learn from this journal article. If you permit me, I will also go to the extent that, so what do we do with these children? I mean, we want to know in clinical practice that I'm faced with this child. What do I do? I have a potential celiac disease, TTJ, IgA is positive, high, and I'm almost certain this will into intestinal manifestations or changes on the biopsy. So what do I do with such a child who's in front of me? He may be having a mild anemia. I'll treat him with oral iron in spite of the fact that I know that oral iron may not work, but I will give it a trial. Now, there were certain compounds which actually bypass the absorptive pathway, but those are not popularly available to us, and therefore we do not generally get those compounds, but we use ferrous fumarate. Give a good trial 4 to 6 weeks, after which you judge the response. If you don't find the good response, you may switch to IV iron. Or if the patient starts having systemic other symptoms of intestinal manifestations, then you must consider IV iron. Okay, IV iron, which iron? That's the next question that comes to my mind. So coming to parental iron therapy, which we sparingly use in children. In fact, I must have used it in not more than 12 to 14 children in my whole career. So you can imagine how rarely you need to use it. But in certain patients, there is no choice. You have to use it. What are the compounds? Earlier on in 1940s and 50s and 60s, we only had iron dextran compound. There were high molecular weight iron dextran, then came the low molecular weight iron dextran, which we used in our practice as interferon. And in fact, Dr. Lokeshwar and me had done a study in 100 children with total dose interferon infusions. And one child had anaphylaxis, and the resident doctor next morning told us, ma'am, we are not going to give iron in this manner to any child henceforth. The child got saved, resuscitated because he was in the hospital setting, but then we stopped total dose interferon. Then we resorted to iron sucrose, which became popular in early 21st century. And that was a good compound. It is again not a best compound because it has very quick decay, and once you give it, so it causes more iron release in the plasma, and therefore anaphylaxis again is known to happen once in a while. It is much lower than iron dextran, but it can cause. Now, having said that, iron sucrose has to be given only up to 100 milligrams every dose, cannot be given more than that at a given time, has to be given over a longer period of duration, about 2 hours, and that is the disadvantage. So repeatedly you have to call the patient every weekly for 100 milligram infusion till you finish the total dose that is required. In contrast, iron sucrose and ferric gluconate, these were second generation. Third generation compounds that came, which are recently available, are those which have a carbohydrate complex iron. Because of that, you have release which is slow from that compound, because of which there isn't significant iron available, free iron available, causing anaphylaxis. And that leads to a good outcome without side effects. Now, the commonest one that is now in use is the ferric carboxymaltose or FCM compound, which is very safe comparatively, even safer than iron sucrose, and can be given as a nearly full dose. So for those who are below 35 kg children, we give up to 500 milligrams at a time. The dose is 50 milligrams per kg, and if it exceeds 500, you don't give it straight away. Above 35 kg children, you can give up to 1000 milligrams at a time, and that is quite a bit which you are giving. So maybe 2 injections may be required to suffice for the total dose. How do we calculate the total dose? The total dose is calculated by the body weight into the difference in hemoglobin that is desired to be increased into 0.24 is the correction factor, plus what you want to add for the replenishing of the stores, that is the body weight into 15. Now, you can't give more than 500. So if it comes more than 500, you limit to 500 and give the remaining later on. This can be given over 30 minutes to 60 minutes. It is a safe infusion, does not have much side effects. And this is the most popular compound, which is recently FDA approved for children above 2 years of age. I think in December of 2021, it got approved. So we have that compound available and we should be using that. I think these were the points which I thought I will make once the article is discussed. So if there are any questions and any
there is a
comments.
question in the chat box. Dr. Chitaramana asked, do we need to screen all iron deficiency anemia with the suspected celiac disease?
So, so if you have suspicion of celiac disease, you must look at them for iron deficiency. That is sure. But in every iron deficiency, I will not start suspecting celiac disease because it's not that common. It's rare. It's 4 to 6% of all iron deficiency or other celiac disease will manifest with iron deficiency as the exclusive manifestation in about 4 to 6% of patients. Though I will find in refractory iron deficiency quite higher number. So if I have non-response to oral iron, those are the patients I'm definitely going to do a TTG IgA if I am not suspecting an IgA deficiency. If I'm suspecting IgA deficiency, I'll go to endomysial also and IgG, TTG IgG, or even do the peptides, gliadin peptide IgG levels. So I will rule out celiac disease sufficiently in a patient who is not responding to oral iron therapy prescribed by me for iron deficiency anemia as a hematologist.
So as per my understanding, as an expert comment from you, you should first confirm that patient taken proper doses of iron in proper treatment and confirm it first and then go for search for other causes. That's right, madam? Because it's a commonest hematologic abnormality in the
I can give you, yes. Yeah. I can give you many examples where patient has been referred to me as refractory iron deficiency, and I have sat down with the patient and discussed, okay, what compound are you taking? I'm taking tonoferon. Tonoferon is a horrible compound. We used to use it, but we gave up once we realized it is not working. This is iron hydroxide, and it is not a good compound because there is a complex which has to be broken by the body and then the iron has to be absorbed. So it doesn't give us good response. So I'm not against a particular company's product, but any such product which is not ferrous fumarate, not ferrous gluconate or ferrous sulfate, you must avoid. And there is a lot of talk about ferric ascorbate now, ferric citrate. And I'm sure pharma will advocate once they have prepared that compound. But let me tell you, there's no scientific evidence to say those are as good or superior to the basic compounds. So go with the basic compounds. They are easily available. There are many brands available. You use the brand as you like. For example, Dex Orange is ferrous fumarate. Hemcy is ferrous fumarate. Vitcofol syrup is ferrous fumarate. So there are many brands. Choose your brand. You can please the company you wish to, but go for ferrous fumarate. That is my take.
Okay.
Second thing is you must always ask the color of the stool when the patient comes back to you for a follow-up. And without prompting them that the color, you would have told them at the beginning.
Right.
To the mother that color of the stool will change to blackish. Don't worry, because you have to caution them also. But she would forget if she is not observing it and she is not seeing it black. And if she's seeing yellow, she will reflexly tell you, no, it's normal. The normal बोलल्यावर जरा थांबायचं. की तुमच्या मुलाला तुम्ही सिरप केव्हा देता, कधी देता, किती वाजता देता, कोण देतं, तुम्हीच देता की कोणी दुसरं देतं, हे सगळं विचारल्यावर कळतं जातच नाहीये. आणि म्हणून हिमोग्लोबिन कसं वाढणार, हवेतनं तर नाही येणार काही. So these are points which we have learned from experience, that first compliance should be confirmed. Once compliance is confirmed, you are definitely sure you're giving a right compound at the right time in the right frequency, then and then only call it a failure.
Thank you, madam. I think a lot of us are so much anemia of the knowledge, and we get lot of proper knowledge dose from you. So, Dr. Mohanty sir want to say something. Please unmute, sir. सर आप अनम्यूट कीजिए सर, अनम्यूट कीजिए सर, अनम्यूट कीजिए
सर, अनम्यूट कीजिए सर.
Thank you, Dr. Manglani. She has come, blessed us with her graceful presence. And ma'am, in general pediatrics, normally we don't venture in the general clubs. We have initiated them into it. Kindly keep on blessing them so that they are more and more, encouraged to do this kind of a job rather than routine presentations. In celiac, I would like to add, it's not only anemia. And under ma'am, your student, Dr. Bhagesri, she is doing a project now. We are investigating anemia cases with microcytic hypochromic anemia, having other telltale evidence, not only isolated anemia only investigated towards celiac, because it's very rare, as you rightly said.
Yeah.
Not in this part of the country, although if mind doesn't know, the eyes won't see. In Pune, Vishnu Biradar has detected so many cases. In Nagpur, that Yogesh Vaikar, because of due investigation, you may detect, because the transport, this traffic is so, now people are going here and there. So people are there, some rare cases are there. But all these cases is a multi-system disease, immune-mediated disease. It can present with like steatorrhea, the basic presentation in diarrhea, chronic diarrhea and steatorrhea. It can present with anemia, as you said, a refractive anemia rather than just anemia. It can present with rickets also, thyroiditis, ataxia, delayed, puberty, recurrent abortions. All these spectrum disease, you look for other telltale evidence like growth failure than only anemia. If you get supportive evidence, then you investigate. In Indian scenario, our diagnostic criteria is little older type, because we do not have endomycin antibody very freely available, and in this private sector, these enzymes are actually not standardized properly. You ask for it, they will not give me. The same sample you send to the another lab, they will give a different result. So unless that lab is doing repeated this kind of studies or say these tests, so we don't rely on their results. That is the issue. People who do that centers, they do it because they standardize time to time. So that's an issue. In India, we use this clinical more important in clinical. Then TTG we do, and TTG is positive. We should also rule out that is no IgA deficiency, because if IgA negative deficiency, TTG will not come as positive. So that you should ensure. And then we do normally insist for this upper GI endoscopy, particularly second part of duodenum, take multiple biopsies. This pale mucosa and scalloping and mosaic pattern and this crypt hyperplasia and infiltration of lymphocytes, these are the few characters. And if it is there, we diagnose. They also say another group pleads, if you get the TTG and endomycin antibody both positive, you need not go in for the biopsy when facility is not available. So indirectly you can treat them if it's a very clinically very suggestive, and you should not debar this child for treatment. So we told that. But there is a problem. Suppose it's a potential celiac, and we withhold the child from gluten, his growth will be compromised. So we have to be very, very careful. Ma'am has rightly said, you can leave these children like potential celiac then and there. As you said, it is a continuum process. Some of them may show the histopathology later part of life. So every 3 to 6 months at least, on iron after iron,
Repeat
do
biopsy.
a biopsy, do a endoscopy, see if they are, some of them have developed or not, then you can handle them accordingly. That's much I can add to it, ma'am.
No, no, absolutely. You added very valuable points, Dr. Monty, and I agree with all of them. I mean, I did not dwell on the GI part because I know you are the expert and I should not intrude myself in that. So very well said.
Keep on blessing us, ma'am, from time to time. We'll request this.
Sir, it is mutual, sir. The blessing.
Thank you, Neman sir, and as well as Mamta madam for blessing this beautiful journey and making more wonderful. So back to our MOC, Manju. Should we
Yes,
move into our second?
Yes. Now we will move to our next article, that is validation of modified Vesicary score in children with acute gastroenteritis in 5 United States emergency departments. To present this, I invite Dr. Sachin Jetlia sir and Dr. Neman Mohanty sir will be there as an expert. And I request Dr. Abasaheb Patankar sir to introduce both the personalities, Dr. Sachin sir and Dr. Neman sir.
Thank you, Dr. Manju.
Yeah.
It's a great pleasure to have Dr. Mamta Manglani madam on the dais. She has excellent inputs on this celiac disease, anemia, how to treat. She elaborately told us how to treat by IV iron therapy, and she is quite honest as well as very upfront saying that it is not that useful because in her career she has done only 14 to 18 patients. Dr. Mohanty sir, my job is to introduce him, but I think it will be dishonor if I introduce him on this platform. You heard him. He is such a humble fellow. He is such a great personality, and he is attached to Raigad IIP. And for Raigad IIP, he definitely needs no introduction. But still, as a format, I'll introduce him. He's a professor emeritus pediatrics at MGM Institute of Health Sciences. He's a member of Academic Council and advisor, MGM University and Health Sciences. Sir has authored so many publications, almost more than 65, and he has authored in book also. Sir is a member of so many national, international chapters related to gastroenterology. Sir is a recipient of Meritorious Service Medal Award from President, and so many things to his credit. And the most part of him, which I have noticed, is Sir is very, very, very humorous. And if you can see his screen, there is a small frame which is hanging behind, which depicts that from what background Sir comes. Sir has got a basically military background, I think. You can see the frame also there. So with this short introduction, Dr. Mohanty sir, you will be expert for this lecture. This lecture is going to be on modified Vesicary score in children with gastroenteritis in 5 emergency departments in US. And to present this clinical journal article, we have got Dr. Sachin Jetlia. He is a president. He is from BID. Ma'am, do you have his slide? Okay, no problem. He is a director of Sri Bal Rugnalaya BID. He has got special interest in field of neonatology. He is a trainer for basic and advanced NRP. He is a trainer for IAP LEID module. He is a scientific committee member of IMA BID. And he is a secretary. He was secretary of AOP BID branch 2023. With this short introduction, I welcome Dr. Sachin Jetlia for his presentation. Thank you so much.
Thank you, sir. Good evening, everyone. Thank you, Patankar sir, for those words. I would like to thank Maha IIP and Raigad IIP for giving me opportunity to present this in this journal club. I think I am presenting a journal article almost after 15 years after my post graduation, and I had got a lot of guidance from Chitra Kulkarni madam and Mohanty sir for this presentation, and I thank them from bottom of my heart. My article is from Journal of Pediatrics and Gastroenterology and Nutrition from October 2013. And the topic is validation of modified Vesicary score in children with gastroenteritis in 5 United States emergency departments. These are the authors. As we all know, acute gastroenteritis is a leading cause of death in children less than 5 years of age all over the world. And research into the therapies for gastroenteritis is hampered by lack of easily used and validated acute gastroenteritis severity scores in outpatient population, because success of proposed intervention cannot be assessed in outpatient population. Many such scores have been introduced, like Clark score and Vesicary score. But Vesicary score has been widely adopted, and particularly for the rotavirus development of rotavirus vaccine. This score is a 20-point score with 7 parameters of diarrhea, vomiting, maximum body temperature, severity of dehydration, treatment, and severity rating scales are less than 7 as mild, 7 to 10 as moderate, and more than 11 as severe. The score mainly relies on the severity of dehydration, that is percent dehydration, which is also a part of WHO dehydration score, like some dehydration, and percent dehydration is also a part of WHO score. And it relies on the eye appearance, condition, level of thirst, and skin elasticity. So its use in outpatient setting is impractical as it is a subjective thing. Another thing is mild to moderate dehydration mild to moderate water loss or volume loss is not easy to access, and reliability and validity of this score is not being tested in a study. So there is a need for in-person follow-up assessment, and it makes it impractical in outpatient settings. In Canada, one prospective study has been carried out in 455 children using this modified version of Vesicary score, and it did not obligate repeat visual assessment. The objective of our study, this study, was to assess reliability, validity, and generalizability of gastroenteritis severity score in previously derived Canadian population, also called as a modified Vesicary score. It is a prospective cohort observational study in 3 to 48 months age group. A baseline MVS score was determined in emergency department. The enrollment of patients was based on availability of trained clinical assistants in emergency department. When present, clinical assistants screened and approached potentially eligible patients after triage, taken their consent for the study, given standard survey forms to for the gastroenteritis symptoms. A baseline MVS score was determined. Along with it, a clinician or treating physician decided a baseline dehydration score, which is a 4-item score of same thing, like eye appearance, condition, level of thirst, and skin elasticity. The patient was followed up for information on phone by research assistant 14 days after the index emergency department visit, and a follow-up MVS score is also determined. They also took diarrhea-related absentees of patients in daycare and parents absentees from the work. The reliability of the score is determined by inter-item correlation, construct validity via principal component factor analysis, and generalizability via score distribution among the sites. The inclusion criteria is children between 3 months to 48 months of age, the symptoms of less than 7 days, those having chronic gastrointestinal symptoms, children with bilious vomiting are excluded. Patients who were previously enrolled in the study were excluded. and those whose follow-up is not possible have been excluded from the study. So what is modified Vesicary score? It is a 7-point score, and what they have done is they have removed subjectivity. They have removed a percent dehydration part from the previous Vesicary score. So diarrhea, maximum number of diarrheal stools in 24 hours, vomiting, maximum number of episodes per 24 hours, maximum recorded temperature, future healthcare visits, and treatment part. All those things are included in modified Vesicary score. Interpretation is 0 to 8 is mild, 9 to 10 is moderate, and more than 11 is severe. In results, out of 282 enrolled patients, 3% were excluded from the analysis because of various reasons. Mean age at presentation was 19 months, and median duration of symptoms before presentation was 3 days. Only 24% of the patients had any degree of dehydration, and out of which 82% had moderate to severe dehydration according to modified Vesicary score. Rate of follow-up was 80%, with success varying significantly between the sites, between 52 to 96%, and this may be because of availability of clinical assistance was different at different sites, and they could evaluate MVS for 100% of the patients, those who followed up. So from this graph, you can see most patients, 84% of the patients are moderate to severe dehydration who presented in the emergency department. And those who missed daycare and those who missed work absenteeism, the parents' work absenteeism is more in moderate to severe dehydration. The overall distribution of MVS severity categories was mild, moderate, and severe, with percentage of 76%, 14%, and 10% respectively. The variation between participating institutions was not statistically significant. So internal consistency of this study was slightly higher than reported earlier in Canadian study, and variability of this study remained low, and that may be because of multidimensional symptoms of like diarrhea and vomiting, as one patient may have diarrhea and other may not have diarrhea. The presentation symptom may not be same for all the patients. So internal consistency is sacrificed in favor of construct validity and generalizability. Finally, they assess cross-sectional construct validity by multiple family and clinical outcomes like dehydration, hospitalization, daycare, and parental work absenteeism. And they detected a statistically significant correlation between MVS and several important outcomes. There were considerable differences in follow-up rates between the various sites, and this was mostly because of research assistant and site investigator availability from various sites and degree of their engagement. So what they could do, or we could do in future for the future studies, is to include dedicated research assistants, have more frequent and scheduled calling, use electronic media for follow-up, and reminders for the information. In conclusion, MVS score performs similarly in different populations and different healthcare systems, like in US and in Canada. Almost same score is useful. It's characteristic for its use in future trials and studies. It is useful for all practical purposes, all cases of dehydration, irrespective of etiology, and main thing is it is for objectively monitoring disease severity as well as predicting the outcome from baseline through the follow-up. This is a latest article from JPGN, February 2022, and it is a pediatric acute gastroenteritis risk score, and it is used to evaluate the prognosis of acute gastroenteritis. Upon external variation, this score can be applied for prognosis, anticipatory guidance, and follow-up care of acute gastroenteritis in children. Thank you.
Nice presentation.
Thank you, Sachin, sir, for that wonderful presentation. Now I will request Dr. Mohanty sir to give his expert comment on this.
Thank you, Manju. Dr. Sachin has done a very good job. In time, he has done it and covered most of the aspects of a journal article to be discussed. I think the study design, the background of the study, why it was thought of doing this. So thank you very much. There is no technicality involved in this, except I have to say that you see the WHO guideline, which is actually meant for no dehydration, mild dehydration, or severe dehydration. It is meant for the grassroots health workers. For doctors, we should take care of the holistic aspect of the child, including the percentage of weight loss, that is the quantum of dehydration has occurred. It will give a direct indication to what should be the treatment and the quantum of fluid replacement. So we should know that. So here in this study, they have used this percentage of dehydration. It's not dehydration percentage, the percentage of weight loss from the normal weight. Other parameters which have been included are also inclusive, say integrated into a scoring system, initially started in 1990, then continuously improved upon, so modified, then the future direction. Dr. Sachin has shown us how the recent article also has further worked on it. So dehydration management, the only purpose is not in a busy OPD practice, particularly in the rural area, in the rural setup in India. We should immediately focus our attention who is the child is very sick. We should need immediate attention and which child will need hospitalization. That should catch first. So this Vesicary score, if the scoring is done, actually it is very easy to do it also. If once you start doing it, in a fraction of a minute, you will be able to complete the scoring. There are very few parameters. If you do that, it helps not only in triaging, it's a kind of triage, which child you should attend immediately, which child can immediately be sent back with some instructions, how to prepare the ORS, mother has to be told. Some children has to be kept there, and there in Sion, if you see, we have a diarrhea ORS corner. It is operating for last 50 years. It has been. So that is, we are very, very happy, and it has given the direction to the national guidelines also. And which child needs your immediate hospitalization, having dyslactodatemia for a correction or any other complication, ATN, AGN, whatever it is. So this is trials, and in our general practice, it will be very worthwhile if we start using this course so that we do not miss any child who is going to deteriorate. So later modification is Vesicary score, as Dr. Sachin has said, is a pager called pediatric acute gastroenteritis risk score. The just modification, it in addition to the trials, it will give you that what is the advantage of this pager is it can predict the outcome of acute gastroenteritis disease. These scores are combined, integrated. It can give a lead what which child can deteriorate. So it's a malnutrition baby, child, he will have more complications, or if he has already suffered from severe insults, the recovery may be slower, may need more time, or who will going to land in the persistent diarrhea, whatever. So in our country where the malnutrition is about 45-46%, these children in diarrhea only simple, is not that simple acute diarrhea. It may push the Fen-Sitter in malnutrition to the severe, next severe grade of malnutrition. So we should now not only screen them for severity, it is a disease severity, than the grading of the dehydration only. Overall severity of the disease we are assessing by Vesicary scores. So that's what I have wanted to add. And with this, I would request all our colleagues to use this pager in the day-to-day practice. That is the whole idea of presenting this, selecting this topic. Thank you. Any question can be?
Thank you, sir. Any questions? Dr. Abasai Patlinkar will take the question and answer session.
Yeah, Mohanty sir, this score appears to be quite easy because it mentions about diarrhea, First is duration and second is number. Again, it mentions about vomiting. First is duration and again number, which is we definitely ask when we take history.
Yeah.
We also ask about the fever. It is also one of the parameters of your score. And future healthcare visits. This will tell us whether this patient has been previously treated or recently treated for this episode of gastroenteritis and what treatment has been offered. So if we want to apply this score, we are not examining patient at this point. At this point of time, we are just trying to guess whether the patient is into triage or not. But why the dehydration part has been removed from this?
Thank you, Dr. Abha. Dehydration part has not been removed. You can see that the percentage of dehydration is also embedded in this score. It is required. See, it is just a triage at the outset before we admit for detailed investigation or the detailed clinical examination of the child. At the instant of the child reporting to in the emergency department, just instantly triage them which is going to have our attention immediately. That's kind of a requirement only. All the parameters like, the specificity and sensitivity of these clinical symptoms and signs. If you see the WHO guideline, many of these scores or symptoms are not specific to dehydration. They found that skin turgor or say mucosal dryness, it is a vague sign, they say. You can mouth breathing will have mucosa look dry. So the skin turgor is one of the important thing, and this capillary refill time is more specific. 3 or 4 signs only are very specific of grade of dehydration, not all. So this is actually meant for not to only decide the dehydration grade, it is only to decide the disease severity in overall, which need more attention, and it can indicate a prognostic factor which child will recover without any problem. And the dehydration is also of course included in this score. All this cannot be included because it's a quick scoring. If you include everything, so it will be prolonged. It's a long drawn battle. The whole purpose will be defeated. That's a very short evaluation. Only included very few signs and symptoms.
How does it score more when we assess dehydration clinically and we do this scoring system?
The dehydration physically, if you score, that is only show you the degree of dehydration. This dehydration score is embedded in this Vesicary score. It is given. It is scored also in a part of Vesicary scoring. The grade of dehydration. This percentage they mention.
Okay, Dr. Dabadkar, sir. Sir, kindly unmute, sir. Dr. Dabadkar, sir, kindly unmute. Not possible? Okay.
Pallavi madam, then allow kara.
Mohanty sir.
Yeah.
Can we get
Yes,
a
sir,
print of
please.
this modified score so that we can publish it in our forthcoming bulletin, and we can have this chart in OPD also.
So I'll give you in 2 days time, because actually this was not downloadable. It's not a free journal. So it's only 1 month has not only 3rd of February the article came. So unless 1 month passes, they will not make it available free. So I promise that I will give you this score.
Thank you, sir.
And
Thank
the
you.
last slide of Dr. Sachin is a concise form of this article. This is a very good slide, and this is a part of that article only.
I would like to add, actually these scores are for outpatients and not for inpatients.
Yeah. For instant scoring on the time the patient report to you in the OPD.
Yeah.
We can put it. We can put it in OPD also. We can train our staff
Yeah.
to categorize the patient. So the triaging will be there.
Yeah.
Dr. Dabadkar, sir, please go ahead.
Sir, thank you very much for allowing me to speak. Basically, I think this history and clinical examination. In our day-to-day practice, we cannot substitute clinical examination to history. All this probably scoring depends on history only, And as Nimai Mohanty sir said, this is best for health workers, paramedical staff, nurses. But as far as doctors, we cannot maybe the severity of dehydration and type of dehydration both are important. And probably, to the best of my knowledge, it is very difficult to know us unless until we do clinical examination. Comments, sir, please. Over.
Sasani sir,
Unmute.
करा.
पल्लवी मॅडम सर्वांना परमिशन द्या.
हो सर हो.
Sasani sir, unmute करा.
Sasani is not audible.
He has not unmuted actually. He's muted.
तर त्यांना परमिशन दिलेली आहे.
Yeah.
Mohanty sir.
Yeah.
We have to see the amount of liquid stool or a urine. There is no mention of urination in all this dehydration child. We should insist whether the child has passed urine, little, some or no urine. How that could be helped us?
It is very helpful. All the history helpful, as Dr. Dabadkar also said. A detailed history is very, very helpful. It is very, very essential to take the detailed history. It is only at the outset when the patient reaches your clinic, which one in the long line. Maybe a short history can you identify with that high risk group. Immediately needs your attention. उसको लेके वो immediately बाहर अलग करना है, start resuscitating this, fluid resuscitating this. That is meant for. If you add all the parameters, it will be a very long run battle. It will not be easy to instantly decide. That is why very minimum parameters have been included in this scoring system. Of course, it goes without saying that you have to take the detailed history. You have to take the if the weight of the child was earlier known. Otherwise, from our own clinical sense, you can also assess which is mild or moderate or severe. So these weight, unless the previous weight, known weight, if you ask the parents, what was the weight recorded the last time you visited this place, they will tell you. It's not that difficult. So we have to ask this question. We do not normally miss these things, and it's not very difficult. All the parameters we cannot include in the scoring system. This is only a shortcut method, not a detailed thing.
Okay.
Minash Sheikh sir.
Yeah, am I audible?
Yeah.
Yeah, thank you for the great presentation. In fact, Sachin did very well. I mean, if you say the way he has presented the entire presentation was really commendable. I do agree what Mohanty sir has been telling that, every score has its merit and limitations and objective. And one of the important objective is to screen. Once we screen, then we can do whatever we want. So a scale cannot have all the clinical details. Of course, we need to have the clinical details once we screen. So the objective of the scale is to begin with screening, triaging, and then from there onwards, way forward.
Yeah,
I do agree what sir has been saying.
I will send you the sensitivity and specificity of each of the clinical symptoms and signs, what we learn in diarrhea.
Yes, Dr. Sachin.
Sir, actually, even during this taking this MVS score in emergency department, a clinician or a pediatrician has already assessed the severity score, means the percent dehydration in OPD. These scores are mainly developed to assess the if you have given zinc and what is its means has it made effect in patient or not, because this is a follow-up score. And second thing, even these scores are developed for rotavirus vaccine during development of rotavirus vaccines for assessing the patients in outpatient setting, not for the inpatient setting. We assess the patient repeatedly in inpatient, not in outpatient. So you have to tell the patient or their relatives what all things to be assessed at home. And you can include this score in that way.
The scoring can be done daily to show the severity of the disease. So whether at home, if it's a OPD case, or at home, at the hospital, is a very useful score. Whether he is progressing or deteriorating, it will get indicated.
Anybody has got any questions? I think I'll hand over to Dr. Manju.
It's okay. Manju is in an emergency. So here it's a time to say goodbye. And I want to thank you, Dr. Mamta Manglani ma'am and Dr. Nimen Mahanti sir, for their teachings out of their vast experience. And many practical points we have learned today. We thank Dr. Jay Bhandarkar and Dr. Abha Patankar for introduction and question answer sessions in spite of their busy schedule. We are extremely grateful to our speakers, Dr. Snehal and Dr. Sachin, and Maha IIP and Raigad IIP President for participating. Also, I'm thankful to Dr. Manju Jaibhai as a MOC, as well as Maha IIP host, Mrs. Vaishali Dharmadhikari, for giving a flawless connection. Good night and see you on 1st of April. Thank you.
Thank you. Good night.
Thank you, everybody.
Thank you.
Thank you.
Bye bye.
Thank you.
Thank you, Snehal and Sachin.
Yes.
Nice job done. Great job
Thank
done.
you, sir.
Thank you.
Snehal, Sachin, very good, both of you.
Agre sir,
Done very well.
Agre sir, good presentation.
Yeah.
Sir, thank you.
Itliya sir, good presentation.
Thank you, sir.
मजा आया.
Pallavi madam,
बहुत
stop live.
अच्छा, बहुत अच्छा किया.
Pallavi madam, stop live.
Yeah. Right now we can.
Yes, sir. Yes, sir.